Okay, well, I think we're going to go ahead and get started here this evening. Thank you all for joining us. We are so excited to have Tony Green from the Department of Health and Human Services Developmental Disability Services joining us this evening to give a little bit of information about the programs and services, and also take your questions and get information out to you that's important for you. I just want to give you a little bit of information first, kind of a housekeeping of things today. First of all, my name is Rhonda Heights. I am a parent resource coordinator at the Munroe-Meyer Institute, where I work with families who have children or young adults who have developmental disabilities, getting them resources. And I'm also a parent of a child with a developmental disability as well. So kind of working with them, helping them kind of through their journey as we've gone through our journey. So a little bit of information just about tonight and how things we would like to kind of proceed. I'm going to go ahead and share my screen here. So hopefully you all can see. Okay, are you seeing the presentation? Yes, okay, good, because I have two screens up here and I want to make sure it works perfectly. So tonight, the goal of the information series has really been to inform families about resources and information to help them to be able to navigate disability-related services and programs. As we all know, it can be really kind of tricky and not necessarily always the easiest systems to navigate when you're trying to get resources for a family member or for yourself. So we're here to maybe try to provide that bridge to some of those services. For tonight, we do have a very large group. We've had over 100 people register for this session. And so we do ask that everyone keep their microphones muted and that we will then be taking questions through the chat. And I gave some of those instructions, but there is, if you're not familiar with Zoom, there is a box down towards the bottom where you can click on chat and then enter your question. And Jennifer will be my wonderful coworker will be monitoring that and taking those questions and getting those ready for Tony when he has a break. So again, please mute your computer and your microphone. We are recording this session. We're hopefully to be able to post it at a later date. We still haven't kind of worked out what that might look like as far as like where to post that and that. And then at the very end, we do ask, there's a quick poll that I will show at the very end. If you would, it's like 3 or 4 questions. If you wouldn't mind just taking a couple of seconds to fill that out, and that will be very helpful for us to get feedback as to what we're doing well, what things we could improve on, and just basically kind of letting us know how we can better make this a format that is good and informative and helpful for families.
We've had a question if the slides are going to be posted somewhere, made available to participants.
So Tony's slides I did send out earlier today, and I can't remember, I was going back and forth on whether or not I was going to send mine, but I don't remember if I did or not. Mine are very short and it just has my contact information on it essentially. But if you didn't get the slides, just let me know, shoot me an email or make a comment. And we can catch that, and I can put your email address in there and I can send those out to you either tonight or tomorrow. A couple of upcoming sessions that we have these every 2 weeks. The next one will be for Social Security Disability on May 12th, Guardianship and Alternatives, and on May 26th, Education Supports. Again, survey would be very, very helpful for us because we want to make sure that we're hitting all the topics that are helpful for you, and again, presenting them in a way that is accessible and informative. So please, help us with that. It'll help us shape and make this better for families in the future. And so, as I mentioned, Tony Green, we are very fortunate to have him with us this evening to give us some information and share with us, all of his knowledge regarding the Division of Developmental Disabilities. So I will stop sharing now. There you go. So it's all for Tony here.
Okay, good evening, everyone. I appreciate all of you taking time. Well, I suppose that the place we're at tonight is taking away from Netflix and deciding to watch me instead this evening. Those of you who have been to other presentations know that I thoroughly enjoy coming and speaking to a group of you and trying to educate as best I can about our complex DD system. And I'll hopefully try and do that as best I can through this means as well. I know it's a difficult process sometimes to have that interaction, but we'll kind of do our best to go through it. So as Rhonda said, the slide presentation that we have kind of walks through, and I won't read each of the slides to you, but what I hope to accomplish this evening is to give you an understanding of what DD services from the Division of Developmental Disabilities at HHS can offer folks. Talk about eligibility requirements, talk about the waiting list, and really at the end of this, I'm more interested in making sure that before you leave, you have your questions that you were hoping to get out of this answered, and do more dialogue around what you want to know versus what I think you want to know on all these charts. You can always take these slides and we'll certainly post them and share them again for those that don't have them yet. So I'll start out just kind of broad overview of the Division of Developmental Disabilities at HHS. We have two primary functions within the division that we operate: our Medicaid home and community-based services, which you'll hear them referred to as waiver programs. And then we also do operate an ICF, or an intermediate care facility, or sometimes folks will still refer to it as the institution, which is the Beatrice State Development Center down in Beatrice, Nebraska. We still operate that facility. And so those are the two primary service functions that we operate. And really what we do within all of those is we determine eligibility for services, we provide funding, and then we provide the oversight of that service delivery that folks are receiving. And those are very high level functions that we do. But that's really the basis of what the division does. We are funded through money that's allocated to HHS, and specifically the Developmental Disability Division through the legislature. We're mandated by statute to maximize our federal funding. So one of the things that I talked about when I say we're a Medicaid home and community-based waiver system, that means that the services we provide are actually funded by Medicaid. And so we're kind of an extension of the Medicaid system in that our services, a large percentage of the payments that we make are funded and receive federal funding by Medicaid. We operate two separate waivers in our division. So you'll hear our staff refer to a comprehensive waiver and a day waiver. And really that comprehensive waiver, kind of the difference between the two, the comprehensive is more all of the services in DD that we have, which include the 24-hour residential that some folks refer to as group homes or shared living or host homes. And then our day waiver, which is generally the waiver that folks get offered when they're transitioning out of the educational system, and we're replacing the day services that the child was receiving through the public school system. And then they remain on the wait list generally for that comprehensive waiver. And I'll talk about that wait list a little bit more when we get to that part of the presentation. But that's really what we do. And so what I want people to understand, you'll hear when we talk about those waivers, that comprehensive waiver or that day waiver, what that means is everybody in developmental disability services qualifies to live in an intermediate care facility. And that's the facility like Beatrice or at the institution. And that's a Medicaid covered service for anybody that's on Medicaid that would meet that level of care. They could go live there. right? Similarly to people that qualify that are on Medicaid to live in a nursing home, they can go to a nursing home and Medicaid will pay. Our folks are eligible to live in an intermediate care facility, but they've chosen not to go to the facility, and they waive that placement for services in the community. So when you hear the term waiver, really what that means is that it's a person who meets the criteria to live in an ICF, an intermediate care facility, but they're waiving that right to get services in the community. So that's my easiest way that I try to explain waiver when folks talk about that, because I know for families and many others that some of our terms that we use in the government, whether at the state or the federal level, don't matter. Bottom line to you is, what is it? How do I get services? And what does that mean for my loved one? And so I try to explain it in ways that hopefully you understand outside of our state and federal lingo. What DD is not. So there's also sometimes a misperception when folks are looking for services, or we've heard families say, well, I applied for Social Security disability. And we want to make sure folks understand that's not what DD in Health and Human Services is. That's a benefit that's through the Social Security Administration. We're also not Medicaid, so folks, that's a different benefit that folks have to apply for. We don't have any financial assistance within our division. We also don't operate crisis services, so we're not an immediate placement agency. We fund folks who then have the opportunity to choose providers, and providers have the opportunity to choose participants. So there isn't a facility, if you will, that we operate in the community where people can be placed in an emergency. This is all a voluntary system, both on the provider side and the participant or the client side. Also, you'll hear, and we'll talk a little bit later about the difference between the aged and disabled waiver versus the developmental disability waivers. Sometimes people don't understand that there's actually 4 different Medicaid waivers in Nebraska. The Developmental Disabilities Division has 2 of those waivers that I mentioned previously, the day waiver and the comp waiver. And then Medicaid has the aged and disabled waiver and the traumatic brain injury waiver. And we're working currently on streamlining those waivers into a single entity that kind of oversees all of that to perhaps cause less confusion, because right now 2 different systems manage the 4 waivers. But we are not the aged and disabled waiver. That's a different program and a service for actually a different population. So let me stop there before I move into what eligibility looks like for folks with developmental disabilities. Any comments or questions on the topics I covered so far?
Tony, can I just real quick interject? Have you been sharing your slides yet at this point?
Oh, no, I don't
Okay,
have.
no, that's fine. I just wanted to make sure that we weren't missing something, because we've had some questions about that. So I just wanted to make sure we were good on there.
Oh.
A question that just came in is, what level of care is needed for the A&D waiver?
Okay. So, and we'll talk about this a little bit later, but briefly what's required for the aged and disabled waiver is they have to qualify for nursing facility level of care. So the day waiver and the comp waiver with DD, those folks have to qualify for the intermediate care facility level of care, and the A&D folks have to qualify for nursing home. So same thing, those folks qualify for nursing home, but they choose not to live there, waive that right, and they get services in the community under the aged and disabled waiver. Okay, so I'll move on to eligibility at this point, and then I'll pause after we kind of walk through all the criteria that are needed for DD eligibility. So in Nebraska, to be eligible for services from our division, you have to be a citizen or legal resident of the United States, have to be a resident of Nebraska, You have to have a disability that began prior to age 22, and the need for services and supports is expected to be lifelong. And those are defined in statute. In addition to the criteria that a severe and chronic disability that includes intellectual disability other than mental illness is the disability. The second component to being eligible for services is, in addition to having the disability diagnosed, you also must have substantial functional limitations in all three of the following areas: conceptual, social, and practical. And so what that means is that through standardized assessments that are generally done as part of the IEP team process for transition age folks, the school systems conduct many of these assessments where they assess the student, or we do it on adults ourselves if they haven't had one and come to us later in life for eligibility. We look at the functional areas of conceptual, social, practical, and scores have to be within a statistically normed range, which means that basically not only do you have to have a diagnosis of an intellectual or developmental disability, but that disability also then has to cause significant limitations in all three areas. And that's required by statute. And so sometimes folks are perplexed why they're not eligible because let's say they clearly have a disability. Let's use autism, for example, because that's a fairly common one that sometimes folks are eligible and sometimes they are not because of the spectrum of the disorder. And so folks with autism disorder clearly have an intellectual or developmental disability that's being diagnosed, but some folks may not have a deficit in all three areas. And an example is a lot of times we see folks that have very high social skills. They're very outgoing, they can carry on conversations, they can comprehend conversations, and so they score too high in the social skills area, which then makes them ineligible because they have to have all three of the conceptual, social, and practical. To define those a little better in everyday life, what those mean, conceptual really looks at skills that talk about concepts, and can you understand conceptually various tasks and abilities. Social obviously is what I was just describing, is your ability to socially interact, comprehend, understand. It's more your communication skills. And then your practical skills they will assess your daily living skills as it relates to daily living, those types of tasks. And so if you don't have substantial limitations in all three areas and have a developmental or intellectual disability, it does render a decision of ineligible. So let me stop there and see if there are questions on how to get a determination of eligible or ineligible from the division.
So far, we only have one question, and they asked, is the criteria different for children than adults?
So currently, it is. For children, the statute allows us up prior to the age of 9. Children do not have to have the substantial limitations or the level of care, if you will. So those kiddos that come to us early on could be determined eligible absent those things, as long as whatever the diagnosis is prior to age 9, we believe that the skill deficits and the disability will continue into adulthood. And so that's the requirement for a child. But what does happen is we're required then, if they apply prior to age 9, is they have to be reevaluated at age 9. You don't have to reapply with us, but we keep track of all the children that are on our waiting list, and once you reach the age of 9 and you again reach the age of 18, we re-verify your eligibility to make sure that skill level still remains at a deficit and that support and the disability is likely to continue indefinitely.
We've had a couple more questions come in. Do the children at the age of 9 have to do that review if they are on the aged and disabled waiver also?
So the aged and, so yes, if they're on the aged and disabled waiver and they're on our waiting list for DD services, which many are, we would reevaluate them at age 9 according to our criteria, because aged and disabled has a different set of criteria to be on that waiver. Again, those folks look at nursing facility level of care. We look at intermediate care facility.
Okay. Can you elaborate further on the 3 areas, conceptual, social, and practical? How does substantial deficit quantify?
So yeah, and I get asked that a lot, and I keep forgetting to just make a cheat sheet from my psychologist for me. I will do my best. So it's a clinical term of the substantial functional limitations. And so these tests that are administered, so one is called the Vineland. That's a fairly common assessment that's used to get these scores. The family, the participant, the teacher, whomever knows the person that's filling out the assessment answers all kinds of questions that say, you know, can they write their name? Can they communicate a sentence? And it's several pages of skills. It takes about an hour and a half to complete that assessment. The answers to those assessments are then placed into a scoring criteria, and based on how the participant answers those and their ability to do those tasks without assistance, it will compute a score. And generally when the clinicians are looking at the normed scores versus somebody who has substantial functional limitations, you would have to have a score, and I know this probably doesn't mean much to you, but it does for the assessors that look at it. A score below 70 in any of these areas does indicate that there's a substantial limitation. And if I didn't explain that well, at the very end of these slides is my email. Absolutely send me an email and I will get some better information on how to articulate that for you from our psychologist that actually does this every day.
My soon-to-be 17-year-old child has an adaptive test in school. Her testing scores have been different from ours as parents to what the school has. Does this make a big difference? Do they look at all sorts of testing?
Yeah, so that's a really good question, and it's not uncommon that you would see a student or child or an adult who over time scores differently. So again, the test is administered. So when we do them, I have staff that administer them, and we generally will just ask the parent the questions, right? So sometimes it really depends on how things are answered, and we try to do a really good job when we're completing them as the state to make sure that the person we're interviewing absolutely understands the instructions to the test, because they do have significant meaning if answered incorrectly. And by that, what I mean is sometimes as parents, we like to, I'll say my kids, I would overrate my kids sometimes, right? And if I'm looking at getting into a system that's trying to determine if my child's eligible, and we're looking at providers to perhaps serve him in the future, I might want to tell you how wonderful he is and kind of gloss over all the naughty things that he does at home and make him not sound so bad, right? But that's actually not a good thing to do, because what happens then is that impacts those scores and it makes it appear like they're higher functioning or the skill level is there when it really isn't. So it's very important that we look at the accuracy of those scores. And so when we get multiple test that look different, it's really the role of our psychologist in the eligibility team. She will try to get through and make a clinical determination based on the assessment. So we'll look at who completed it, how long ago was it completed it, how much time is the person in that environment where it was completed. And we try to give clinically significant opinions then on our interpretation of those tests.
Okay, we've got a few that have come in here, a few more. Is the state review team involved in the children's eligibility determination?
They are not in the DD eligible. If they're statutorily eligible, the state review team is a process that is looking at disability as, excuse me, as it relates to Medicaid eligibility, not DD eligibility.
Okay. I was told by my DD services coordinator that this week that there is not a re-evaluation at age 9.
Well, you send me her name because that.
Maybe just a comment more than.
Yeah, that's not. Now, again, make sure if you're talking about the eligibility for the DD waiver, and you're not referring to somebody on the aged and disabled waiver, because that has different criteria, and sometimes folks get those mixed up because they too have service coordinators.
Okay.
So if it's the DD waiver that somebody is either receiving or on the waiting list for, we are required by statute to redetermine eligibility at age 9 and 18.
Okay. Another question. How does this affect children diagnosed with a high-risk pediatric cancer?
I'm sorry, what was the first part? How does
this affect children diagnosed with a high-risk pediatric cancer?
So I would say those folks generally are not in our developmental disability waivers. Those folks are actually on the aged and disabled waiver that have the medical conditions that make them eligible for nursing facility level of care. So I think that's probably a question more geared towards the other waivers, and we don't see that, or those aren't the folks that we're serving under these two waivers in DD division.
Okay. What is currently being done to reduce the wait list? I'm aware that there's a campaign from ARC in Nebraska to end the wait list and to get funding.
Sure. Good question. So there are a few thousand folks on the waiting list. What is being done to end that? So there is a push from advocacy groups to get the legislature to fund the division to make movement on the wait list. I think ideally we all, including myself, in charge of the division, would love to see the waiting list go away and that everybody who is eligible could receive services. Now, that being said, we all know that that takes a significant amount of funding from the legislature to appropriate to our division. So currently, we're serving just under 5,000 folks across the state on these two waivers. And if there were another 2,700 folks that needed to come into services, obviously that I would need at least, well, probably quite a bit more, because what comes with that is not only the services that we would have to pay for, each of those has to go onto a service coordination caseload that are at 1 to 25, and so I would have to hire that many more staff to do the case management for them as well. So there's a service dollar cost and a staffing cost to take on that many folks into the system. So it is a pretty significant dollar amount when folks look at what would it take to serve the entire population off of the waiting list, that's where you will hear figures somewhere around the tune of $75 million to remove everybody. And so while I would applaud that if that were handed to me and given to my budget, I would welcome serving all them. But I think the reality is we all know that our senators are faced with limited budgets, limited revenues that have multiple needs across the state. And so I am all for movement of the waiting list and support that. I think the issue is always trying to find the appropriate funding to get that done. And then maintained, right? Because once you do it and you take people off of the waiting list and remove it, if you eliminated it completely, you also then have to have a commitment of continued funding because new people apply every day. And so if your goal is to not have a waiting list, you have to have a commitment of resources to also then fund not only everyone on the list, but everyone who applies in the future, which is about, we generally process about 1,300 applications a year for developmental disability services. So long answer for that, but very good question.
Okay, would you like to keep going with the questions or continue with the presentation?
Let me run through a couple more because I think
Okay.
some of them are in some future slides, and so I'll try to get a couple more topics
Perfect.
down and we'll pop back to those. So when we talk about applying for developmental disabilities, we've made the application much more simple than it used to be. I'm sad to say that we used to have like a 14-page application that we were expecting folks with disabilities to complete or their parents. We've condensed that significantly. I think our current app is maybe 7. You can do it online through Access Nebraska, which is the easiest way to just go on, fill out some basic information and submit. And then our disability team will receive that and assign a eligibility worker to begin processing the application. Once it's received, the other thing that we've changed is we used to have a process in DD where we required the families to submit all the records to us. So you had to go to the schools, the doctor's offices, and go track down all the evaluations and the records that we needed to make a determination. And some parents still do that. Some of you have very large files that you keep at home of all the papers that you've ever had and easily can pull those out and send them in. And that's great if you have them, but we also don't want to stress you out in not knowing what we need. And so part of that application process now is just a release of information that you sign that then authorizes us to go get those records for you. So you could tell us that you authorize us to go get records and they would be at Westside Public Schools and they would be at Munroe-Meyer Institute and Dr. So-and-so. We'll then contact those entities and we'll obtain all of the necessary evaluations that we need from them in order to make our determination. So hopefully that those two changes of a more shortened application and the ability for us to just go get the records on your behalf, make that process on the front end very easy. What happens after we get all of those records and we review them against the statute? Again, from previous slides, you'll remember the two questions we're looking for is, do they have a diagnosed intellectual or developmental disability? And do they have substantial limitations in all 3 areas? Excuse me. Once that's made, then we have what's called a notice of decision, and that's sent out to all of the applicants. And you'll either get one that says you're not eligible or you're eligible, right? There's really only 2 decisions that we make at eligibility, and it's either you made it, you're eligible, or the records don't show that you are eligible. If you get the ineligible record or notice, you always have the right to appeal that decision, and there are instructions right on the notice of how to file that appeal. And I, you know, again, I think it's always good to have somebody look at that again and make sure we're on the right track. If you're eligible, then generally what will happen is you'll be contacted by us, and I have a program specialist that oversees all of the eligible folks that are going to be going on our wait list. She will reach out to each of the families or the individuals if they're adults and their guardians, and let them know that we got the information, they've been determined eligible. If they have Medicaid, they'll be placed on the waiting list, and they have the opportunity at that point, if they want one, to have a service coordinator. If they have Medicaid, because that requires us to bill Medicaid for the service coordination piece. And if they don't have Medicaid at the time that they apply, absent children under 19, if you're 19 or over, we would tell you that we can't technically put you on the waiting list until you get your Medicaid activated. So once you get that eligibility notice, that's just saying you meet the criteria by statute. Now we have to do the steps to get you eligible for the waiver, which is you must have Medicaid in order to access our waiver services. And so if you don't have Medicaid, we would be telling you to make sure you get that. Eligible folks can have a coordinator. Again, funding is based on availability, and we would also be looking at that level of care for the ICF. I'm going to go through a couple more that all address waiting list and funding because they tie into this. So the assessment of need that we look at, when I talked earlier about the level of care to determine who meets criteria for the intermediate care facility, we do that every year on folks. So it's part of the eligibility process. It's required to go on the wait list. We also complete it if and when a funding offer comes available. And then everyone in services or on the wait list has an annual level of care done, making sure that they still meet the criteria to live at the ICF. You'll also hear something referred to as the objective assessment process. That's done once folks have services and are offered a waiver slot and accept it. That's called an ICAP. You'll hear that term a lot. It stands for an inventory of client and agency planning, but it's an assessment that we use to assess needs and then subsequently determine a budget that gives you purchasing power to buy services. But again, those are only done once you get into services, and then we do them every 2 years after that. The waiting list, again, we talked earlier, there's certainly not enough funding today to provide services to everybody on the wait list. So we maintain that. We track where folks are, annually assess their level of care, make sure they're on Medicaid or they're under 19. And then eligibility is reviewed at 9 and 18. And funding or services are offered when funding becomes available. And the next slide is really where you want to look at how do folks get funding into developmental disabilities. And this is just taken straight out of statute for the funding prioritization. So our first priority, if we have $1 in our budget to serve somebody, I always have to look to what we call priority 1, which is people that are in crisis. And you can see there that the reason somebody is in crisis by statute needs to be due to caregiver death, homelessness, or threat to life and safety of the person. The second group that I would have to look to, if I don't have anybody in emergency status, but I had some money, I'd have to go then and say, are there any priority 2s who are folks that have resided in an institutional setting like Beatrice or a nursing facility, and they've been there for 12 consecutive months and they want to come to the community. I have to look to that group next and allow them to come out of Beatrice or allow them to come out of the nursing facility and receive services in the community. Our third way to get funding from the division is those folks that are served by probation or the child welfare system. And they're going to be aging out at age 19 of the foster care system and don't have a place to go. That's the third group of folks that we're required to look at for funding. The fourth group, if we have money and no one else above has needs, we would look at those folks transitioning from the educational system at 21. So this is the group where we've been able to every year offer the day waiver for all of the graduates that are turning 21 at the end of that school year. We use that fourth priority under statute. Excuse me. And so far, we have always had the budget capacity to get all of the 1 through 3s and the 4s. We've not had a year yet that we've not had funding to serve all the graduates that want to be served. The fifth priority that was recently added a couple years ago in statute is those folks that are a dependent of a military family who are stationed here in Nebraska. Again, they still have to meet the Nebraska eligibility requirement. So sometimes there are folks in other states who were eligible for DD services but move here, and each state has their own criteria. And so sometimes those folks think that because they have DD services in one state that they transfer equally to another, and that's not the case. We will prioritize them for funding as a P5, but they still have to meet the same criteria that all of our other folks in Nebraska have to meet. The final group of folks that get funding from us off of the wait list are everyone else by date of application. And so that's the 6 areas that we go down the list when we start looking at how folks move from that waiting list. So now that was a lot to cover, and I'll take time to try and explain that with questions you have.
One of the questions is, how long currently is the wait list?
Good question. I would say right now we are still about 6-7 years back. Again, it's somewhat misleading because there was an old practice previously that many of the people on the waiting list have been offered services in the past, and they declined those services, but they wanted to stay on the waiting list. So while we say that there are 2,700 people on the waiting list, many of them have been made multiple offers over the years, but they denied the offer, but wanted to stay on the list just in case. That practice changed a few years ago under the authority to administer the waivers that said we no longer have that practice, that if your name comes up and you're eligible for funding, if you do not take the funding, you are removed from the waiting list and you have to reapply. Because what it was doing is it was holding a lot of people that were further down the list from ever moving up, because we always had to keep going back to those people that had been denying services over the years. And so when we switched to a true waiting list from an actual registry of unmet needs, that was the old term that was being used for the wait list. Truly, to be on the wait list, you have to be eligible for and needing the waiver services. And when they're offered, you do have to accept them, or you will have to reapply and start over at the bottom of the wait list.
My daughter has been deemed eligible for DD as a child,
Okay.
and now more recently as an adult. She's 19. As I understand it, although she is eligible, she must remain on the wait list as services are not available until age 21, even though she has graduated from high school. Is this correct?
Yes. So the statute for that priority 4 that was on, well, still there on the slide. So the way it's written in statute is we will prioritize folks that graduate and transition, but the statute also says upon attaining 21 years of age. And why that's in there is at the federal level, they administer funds to various different programs across the states. And each of them are very protective to say, and we won't pay for anything else that another federal entity is responsible to pay for. So under federal law, students who would need assistance, which all of our folks would because they're carrying on into adult services, are eligible to continue receiving services under their IEP from the school system through the school year in which they turn 21. So if a child and family decided to go ahead and graduate, if you will, prior to 21, unfortunately, even though they graduated, I can't, under the statute, bring them in until they turn 21 because technically they have a right to stay in school and receive services until 21.
What happens to an individual's funding when someone leaves DD services or perhaps or becomes perhaps deceased? Does that automatically release someone off of the wait list?
Good question. So the short answer is yes, that we call it the attrition, right? So folks that either leave the waiver voluntarily who no longer need it, or as your example illustrates, folks that would pass away and their funding becomes available. That money just stays within the DD budget, and then that's what we use to start going down the prioritization list to see, are there any P1s in emergency crisis? Anybody want to leave the institution? And generally all of those folks are on our waiting list too. So once we give them an offer, it does move them off of the wait list. And so it does have an impact of the wait list. It's a much slower process, obviously, than it would be if somebody said, here's $3 million, make 100 offers from the wait list. So it is a slower process when we do it through attrition, but it is used to fund people from the wait list.
Okay, maybe one more. Is the coronavirus having any effect on applications as time-wise or in getting the information?
It is actually. So as you can imagine, schools are open, but they're educating students in alternative settings, which generally means our teachers aren't at school like they used to be. So when we're needing to get records currently for students, it is taking a lot more phone calls and creative ways to get a hold of folks to obtain some of those educational records. Similarly, when we need to get records from doctors' offices and other clinics or professional evaluators, many of whom are also no longer seeing patients except on emergency basis. So we are seeing a slowdown in responsiveness from professionals, but it's certainly understandable, and folks are getting back to us. It's just not as immediate as it used to be. The number of applications, I didn't look this last week to see if they've been coming down. I've just heard from the eligibility staff that it's taking longer to process just to get those records right now.
Okay, would you like to go on with the presentation or do a few more questions?
Let's see what I have left. I can do questions.
Okay. Is a family's income figured into Medicaid eligibility if they are eligible for DD and there is a slot open?
Okay, good question. So children living with their family, when we look at DD eligibility, we're not focused on the Medicaid piece. The Medicaid piece comes in when they want to be, they have to have that to receive a funding offer. So children, we allow them to be on the waiting list even though they don't have Medicaid up until the age of 19. And the reason we do that is prior to age 19, in order for that child to get Medicaid, the family has to qualify for Medicaid outright, meaning that the resources of the whole family are factored into Medicaid eligibility. And so if the family's income is too high for eligibility, then the child will not be getting Medicaid. And so we know that, but we leave those children on the waiting list Because if there was a child, let's say 10 years old, and if we were going to make a funding offer to a 10-year-old and they didn't have Medicaid, there's a rule under Medicaid eligibility that once I make that funding offer for DD and they're a child under 19, they automatically can have their Medicaid eligibility determined without the parental income, and they can be treated as a household of one. And so they automatically become Medicaid eligible when I give them the waiver slot. I know that's confusing, but we require then at 19, so we send a letter out to families, generally, I think we're sending it when they're 18, that tells you at 18, we really need you to go get Social Security, SSI, if you haven't got that determined yet. At age 19, you need to make an application for Medicaid because they are now in Nebraska considered reaching age of majority and they're an adult at 19. At 19, they qualify for Medicaid on their own. And so we encourage folks to make sure that they apply for Medicaid at age 19. That way it's in place and ready to go when they turn 21 and have that offer from DD. We don't have to wait for that Medicaid to be active or for you to go through the application process at that point. But hopefully that explains the child issue. Children's eligibility for Medicaid is based on the family's income under age 19.
Does Social Security benefits need to be in place as well as Medicaid to qualify or to come into services?
Yes, so we need that because they will determine the disability, which generally in many states your Social Security determines automatic Medicaid. So if we have a person that Social Security says they're not disabled, that would trigger a review on our side to see if they're actually eligible then for DD. But yes, we do require, because what's going to happen if you buy, let's say you go into residential services, the state is prohibited under Medicaid rules from paying any room and board payments. And so if you were to live in a residential setting, DD pays for the services and the staff of the provider, but the client is responsible to pay their room and board payment. And generally they pay that room and board payment out of their SSI or their Social Security.
Okay, another comment or question here regarding application. Based on date of application, then folks should be encouraged to apply as soon as possible?
Yeah, so it is the folks that go on the waiting list, we do encourage, you can apply as early as you want because you are placed on the waiting list by your date of application or your date of Medicaid eligibility. So again, this gets confusing for the kiddos. If you're a child, because you can't let's say your family makes too much money and you don't qualify for Medicaid, we're going to place you on the waiting list based on your DD application date. So yes, we encourage you to get on as early as you can. If an adult came to us today, brand new to DD, and they're over 19, and they applied for DD and they were determined eligible, but they didn't have Medicaid, we would tell them, you're eligible for DD, but we can't place you on the waiting list until you get Medicaid, because a requirement to be eligible for the waiver is to have Medicaid. So let's say that person applied today on April, what's today, 13th maybe? But then their Medicaid application, they apply for that later, and that becomes effective July 1st of this year. They actually go on the waiting list with the July 1st date because that's the date they became waiver eligible. Whereas children, because they're not eligible for Medicaid unless outright with the family's income, they'll get to use their DD application, assuming that they'll get Medicaid at 19 as a family of one. So the short answer is yes. If it's a child, we encourage you to apply early. If you're an adult, we also encourage you to apply as soon as you can. But that requirement to be on the wait list for adults, the Medicaid must be there in order to get placed on the wait list.
Why would anyone decline services if they get respite and other services?
Yeah, so good question. I think the folks, we have a lot of folks that families have just taken care of their children and now their adult family members. And sometimes accepting that government assistance hasn't been an easy task. They want to keep their adult child at home as long as they can. And so they've just said, not now. I might need it in 5 years, but today we're just fine. I'm taking care of my son. He's doing great. We don't need anything, but we want to stay on there just in case. And so that's one example of why we have seen folks deny. I'm sure there are many other reasons that families have, but that's been a fairly common one.
We have a question here about Appendix K. I don't know if you're going to get to that or if you want to hit that now. So once services have been approved and they're in place, please explain what Appendix K is and how it will affect current services.
Okay, perfect. So I'll give you the high-level overview of what all that question means. So when I talked about our waivers, the 2 waivers that we operate in DD, each of those waivers has a set of services with service definitions that dictate how those services are to be delivered. And those then are approved and adopted by CMS, the Centers for Medicare and Medicaid at the federal level, and they approve the state to operate it, and we're able to draw Medicaid funds down. Appendix K is the appendix, well, it's an appendix to your waiver, but it's really for emergencies and disaster preparedness in states that are experiencing emergencies or disasters. We used an Appendix K last year when we had the flooding and the severe blizzards out in western Nebraska simultaneously. So it's not something we haven't used before. I've only known of the one time last year, and now we did recently submit an Appendix K due to COVID-19. We received comments late Sunday night. I got those from the feds, and we worked on responses yesterday, and this morning we resubmitted answers to their questions. But what the Appendix K does is it allows states flexibility in their waivers to continue to deliver services and meet the needs of our participants while the pandemic is going on and causing us some difficulties. So a good example of what's in that Appendix K would be day services. So typically you see a lot of folks that go to agency providers at congregate day sites, or they call them hubs, or the old term workshops, where lots of folks went, they received their day services, perhaps went out into the community on outings, things like that. Due to the directed health measures that are here for COVID and the requirements for us to social distance and be in groups of 10 or less and to stay 6 feet away, it becomes impossible for those centers to stay open and operate. So day services were closed. But folks, especially those in the 24-hour care, still have to be supervised and still have needs to be met during the day. But the definition of day services right now says it's in a day site or in the community. The Appendix K allows us to modify the definitions within the waiver to say, we're still going to support somebody during the day, but we're going to do it in their home. And do we have permission to do that and pay for it? That's a simplistic example of one of the flexibilities we asked for in an Appendix K. We also asked for flexibility to do some services via remote, like this, via Zoom or WebEx. Some of our higher functioning folks had staff that would periodically go in and check in on them. Maybe remind them to take medications, things like that. And perhaps some of that can be done through technology. If the participant has the skills to do that, that we can check in, do the reminder, take your medicine. So it allowed for that flexibility. It also allows for an increase in provider payments, because we know that the rates we currently pay, providers are sustaining increased cost because of the pandemic. They're having to pay a lot more overtime. They're having to purchase a lot of additional supplies, whether it's disinfecting supplies or masks or gowns, additional protective equipment. So we did a rate increase, and that's one of our requests for flexibility. And then another thing you'll hear referred to as retainer payments, which is a flexibility of paying a provider when services couldn't be rendered because the participant was at home isolating. So a lot of providers are experiencing significant amounts of lost revenue because a lot of our folks that live at home with their families, they're staying home with families, rightfully so. And the families are saying, no, I don't want any staff coming to our house and providing services. We're just fine. We don't want to expose them to any more folks, and we don't want people coming into our home. So the provider's not being able to collect any revenue, but still has to pay their leases and their overhead. And so the retainer payments is another flexibility that allows a payment to a provider when they couldn't deliver a service because the client was impacted by COVID-19. There are a few others that I won't bore you with to all the details, but those are some examples of the flexibilities that we wrote into an Appendix K. Again, we resubmitted those this morning, and I am hoping that in the next day or two I have the official approval from CMS that we can implement those changes.
Okay, you just tell me if you want to keep the questions coming or you'd rather get to the presentation.
I'm actually fine with the questions because I think that's what they want to hear about rather than me read some slides to them.
All right. Do you have any suggestions or thoughts for a family who had to turn down DD funding at graduation because level of medical need required them to stay on the A&D waiver? But this individual has potential to participate in the community with nursing support. We are stuck at home with no access to the community or to peers, etc.
Okay. And it'll be hard to ask some follow-up questions because that one I would have to say, if you could email me, again, my contact information will be at the end of the slides. And if you want to jot it down now, it's just Tony, Tony.green, just like the color, at nebraska.gov. I would have to ask a few more clarifying questions before I could actually answer that with the correct answer.
Okay. How often does Medicaid eligibility get reassessed? At age 9, are both Medicaid and DD reapplied for?
Yeah, so Medicaid is an annual renewal that's required. So folks on Medicaid will get an annual reminder to submit paperwork for Medicaid eligibility. DD, we do eligibility at the time of application, and if you apply prior to the age of 9 or 18, we will reassess DD eligibility at 9 and 18. After 18, we no longer assess the statute DD eligibility, but we do assess whether you continue to meet level of care for intermediate care facility, which is very similar to the substantial limitations that you see in the statute. And we do that annually for folks on the waiting list, and we also do it annually for everyone on the waiver.
Okay, do you have any idea of how many individuals you were able to offer a spot on the waiver last year based on date of application?
From the P6 category? I don't off the top of my head here at my lovely home office, but I absolutely could get that for you when I'm at the office. So whoever has that question, again, feel free to reach out to me, send me an email, and I'll certainly get you that data.
Okay. What is the definition of homelessness? My 21-year-old lost his apartment last July and has been sleeping on a cot in my living room, or laundry room, excuse me. He has been on the wait list and his case manager has placed him on priority 1, but it has taken months to get approval for residential services. What can we possibly do to help speed this up?
Yeah, so I think you've done the right steps so far. So if the coordinator has completed what we call a service needs assessment, that's the official name for the paperwork that they fill out that describes the priority 1 need. Now they are required to ask questions about, have you tried other alternatives? You know, are there other things out there that the person could be doing? But at the end of the day, if there is nowhere for the person to go, and the family cannot meet their needs safely, then we have looked at those folks of being homeless. It's a tricky determination, because obviously I think the true definition of what we all see as homeless, I mean, we know what that looks like, right? And we certainly have DD folks that I literally have been had to go to parks or to homeless shelters to actually pick up and provide service. That's easy homelessness to define. This example is a little more difficult, but still relevant, because although parents will always do the right thing, and no one's going to just turn a blind eye on their child and move them out, what we begin to look at there then is, for those folks that are at the parental home and they're in their adult ages, is what's the burden that's placing on the family and the stress. And if it wasn't for that family member out of the kindness of their heart doing it, would they be homeless? And generally the answer is yes. But we have to be careful, right? Because there would be a couple thousand adults on the waiting list that people would say, well, I don't want them at home either. And so how do I get money, right? And I don't mean to minimize the question, but we have to make sure we assess it, that there really is a true need that's making them homeless, as opposed to this just isn't the best arrangement. And I don't have an easy answer of how we determine it, but those are the questions that the coordinator tries to articulate through that service needs assessment that they send into central office for us to review.
Okay, if a child already has a DD slot, they're on the wait list, I'm guessing. Let's say nothing significant changes in their condition. Would they ever be deemed ineligible? If they have a DD slot already, then will they always be Medicaid approved as a household of 1?
Once they have a DD slot and they're Medicaid eligible, will they always have a DD slot? Is that what's the...
So if a child already has a DD slot and nothing significant changes, would they ever be deemed ineligible? That's the first question.
So I'm going to answer it as though the slot means they're actually on the waiver. Would they ever be determined ineligible? It can happen if needs change, but if the example is needs never change, not likely. But again, it's dependent on the answers to those questions that we would do on that level of care, that if folks begin to gain skills in their daily living, there are times that people get to a level that it doesn't mean you don't have a disability or don't have needs, but you don't meet the ICF level of care. And I think that's the one difficult thing for folks to understand services from DD, is there's a belief that anybody with a disability should be getting services from the Division of Developmental Disabilities. And that's not how the statute's written for our services. Our statute is written that we absolutely will serve people with developmental disabilities, but only folks that meet this level of need, which is the severe need to live in an institution. So folks that maybe are higher functioning or have some skills, nobody would argue that they perhaps don't need support somehow, but they may not qualify for services from us because we only serve folks according to statute, which is the highest need folks with disabilities. So the answer is sometimes folks can be determined ineligible after having been on the waiver a number of years. I don't see it a lot, but it does happen.
Here's an interesting one. How will the Medicaid expansion affect a person on the wait list?
It should not impact folks on the wait list, because in order to be on the wait list, you already have to have Medicaid. Now, it potentially, depending, although we've analyzed it and don't think that it will really impact our population that much, but we'll have to see once it's actually rolled out. Perhaps somebody has a disability and the only reason they were denied Medicaid was because they were slightly over the federal poverty level. That perhaps with the new income thresholds, now they're eligible for Medicaid, which would, if they still have IDD, would allow them to now be on the wait list. But again, we don't generally see folks with disabilities not qualifying because of resources. That's such a small population of folks that we don't really see that that's going to have a significant impact when expansion is implemented.
Okay, we have a question here about the actual services of DD, and then we have a few more Appendix K questions. If a child becomes eligible and receives a funding offer, what sorts of services would DD pay for?
So if they're eligible and we get an offer, it will be dependent on which waiver they're offered. If it's an offer at 21 because they're leaving the school system, we're going to be offering the day waiver. Under the day waiver, there's an array of services that's available that would include respite. It would include some day services, whether that's the HAB workshop, the HAB community inclusion. It would offer them the supported employment services, and it also gives them a limited number of hours of independent living or supported family living. And those services are independent living means the person lives in their own apartment on their own, but needs intermittent staff to come in. Supported family living means they live at home with family and need intermittent support of staff to come into the family home. So those are the services under the day waiver that people would be eligible for. And then there's a few other services that are not respites in there, homemaker, you guys are testing me off the top of my head. Respite, homemaker, transportation, a couple other ancillary services that we don't see a lot of utilization. Then if you're being offered actually the comprehensive waiver, it's all of those services plus the 24-hour residential, which is the group homes with providers, the shared living homes, or host homes, some people call them, with providers. That's the major difference, is that service is added into the comp waiver that's not available on the day waiver. So a lot of folks equate the difference is this one doesn't have residential, this one does, even though the day does have residential, but it's limited to only folks that live in their own apartment or folks that live in their family home. It doesn't allow you to purchase the out-of-home residential that most folks typically are wanting at some point. That's in the comprehensive waiver.
Okay, maybe just one more question here about the child before we get to the Appendix K. If a child applies for DD services and becomes eligible at, let's say, age 7 and meets the criteria, could they, sorry, we're at home, could they potentially get residential / comprehensive funding prior to age 21, or do they still have to wait the 6 to 10 years on the comprehensive waiting list?
It is possible that folks could get that if we make movement. So the folks in that situation as children generally are only going to get the comprehensive waiver under two ways. Either one, as that priority one, if the child would for some reason become homeless, the caregiver dies, or there all of a sudden becomes a serious threat to the life or safety of that person. The only other way generally that children will come in is under the state ward program, aging out of foster care, or the P6, all other folks by date of application. We have very few children in our system because we are an adult system. Out of the 5,000 folks that we support statewide, we have around 100 children, maybe a little more, but it's not a large percent of our population. Most of our folks are adults.
Okay. Will Appendix K allow for an independent provider that is not working now due to the client's need to stay isolated due to the COVID situation be able to receive retainer pay or pay for the hours he would have worked?
The short answer is yes. There is that flexibility within retainer K or Appendix K for retainer payments in that situation. The one thing we are working on clarity is because there's been an expansion on the eligibility for unemployment, if the independent provider is collecting unemployment, we have to see if there's any impact on retainer payments. But if they're not collecting unemployment, currently in Appendix K, that situation would be eligible.
Okay, with Appendix K, can school-age children receive services from DD if they are on the waiver?
So I had announced yesterday on a family statewide call, this is a significant issue for us. And if any of the families out there are in that situation today, the dilemma that we have here in Nebraska is that schools are open, right? Although nobody's going to school, they're deemed open by the State Department of Education. They're required to educate in alternate settings. So you're open, but you can't come to school, is really the message that's out there. So it has put districts in a very difficult spot to figure out how to still meet the requirements of educating both their general population of students and then all of the students that are under IEPs, the individual education plans. Reality is today, we know that our folks that we're getting special education services are receiving very limited, if any, services from their local school district. And I have heard it now for a month since schools closed that parents are struggling. There aren't options. The school is not sending paras, obviously, to everyone's home to do one-on-one supervision. And so we're in a difficult spot in that schools are open. When schools are open, the federal rules are that they're obligated to meet the needs of students. And obviously our kids need different things. So yesterday I had said, CMS is going to allow us under the Appendix K that if children are at home and they're not receiving any services, or during the time that they're not receiving services from school, I will in the interim go ahead and pay for waiver services during that time, just like I would in the summer when school's officially out or during Christmas break. We've always done that. We paid for day services when schools closed. I'm considering the fact that schools are open, but services really aren't truly available to our kids, that makes them eligible for waiver services. Now, I still want the system to push back and have conversations with local school districts about what will the school provide. So there are some districts today that are providing, let's say, 5 hours a week of special ed instruction that they might be doing over Zoom, or they might be doing speech therapy via telehealth. So what I'm saying is that I'll pay for things that the school wouldn't be covering. So if they're currently getting 5 hours a week from their school, then they would be eligible under the waiver for 30 hours because we pay for up to 35 hours of day service time. On the back end, I will work with the advocacy groups, the State Department of Education to figure out how this really should have worked, because in all honesty, I shouldn't probably have to put forward waiver services, but I know today that kids aren't getting any services for the most part.
Okay, what was the increased rate requested for CMS approval?
The requested what?
What was the increased rate requested for CMS approval?
We requested a 15% rate increase to certain services, to adult day, HAB workshop, HAB community inclusion, independent living, and supported family living. We asked for a 15% increase to the current rate.
Okay, are the retention payments strictly for agencies? For example, a supported person goes home to family during the COVID-19 crisis. That supported person is typically in an SLP. Is the agency being directed to fulfill those contracts with SLPs?
So the payments or retainer payments are for both agency and independent providers. The flexibility to provide services in alternate settings like a shared living home. So if somebody is currently, let's say, living in shared living, and they normally went to that provider's day services, but the day services are, the client is now staying home with the shared living provider and providing all day and 24-hour supervision basically, but previously had only been paid for the residential portion. The provider is going to begin billing me for the day portion. And again, some shared living providers are some contractors of the agencies, and so it's up to them how they pay their providers, but we are expecting then that if the current arrangement is 80% of the revenue for residential goes to the shared living, that same percentage of day service revenue goes to the shared living that they would be billing me for. So the shared living provider should be compensated for both the day and the res when they're providing it.
Okay, you started talking about how DHHS might consider combining waiver programs. Can you provide more details on what this might look like?
Yeah, so we are in the process right now of beginning to build what eventually will be just a home and community-based service unit, right? So again, there are 4 different waivers in Nebraska: a TBI waiver, traumatic brain injury, and the aged and disabled waiver, currently being administered by Medicaid. And then the day waiver for developmental disabilities and the comp waiver for developmental disabilities. The plan long-term is that we begin to oversee and provide guidance and support to all 4 waivers in a consistent manner. So for example, service coordination. Service coordination is a function that happens on all 4 waivers. That you get a service coordinator, they're responsible to have the team meetings, look at your needs, and develop a plan. But today, that looks different on each of the waivers, depending on who does your service coordination, whether it's a state employee, a contracted entity, and all we're looking at is bringing some consistency to the processes that a plan for any one of the waivers is a plan. And that really we build a system someday so that families can go to their service coordinator and they could lay out the 4 different waivers and have conversations about which one will best meet your needs. And we don't have folks saying, I don't know what the aged and disabled offers. I'm a DD worker. Or the aged and disabled saying, I don't know what DD does. I'm an aged and disabled waiver. And many families, unfortunately, you've experienced that, where we don't talk well across the divisions. And so really what I can explain at this point is we're trying to break down the silos between the divisions and see if we can set up a supervision structure to where we support all 4 waivers in a consistent manner.
Okay. My son was getting services and had Medicare, but lost services when his father died. Can he get Medicaid and his services back?
That one I would say, again, you'll have to email me on case specific stuff that I couldn't and probably don't want to. I know it's not identifiable, but there's a lot more questions I'd have to ask before I could just say, you bet.
Okay, we were transferred from the A&D waiver to the comprehensive DD waiver.
Okay.
My son is 8 and about to turn 9. Will he still be eligible for Medicaid as a household of 1?
Yes, as long as he remains waiver eligible, the waiver slot gives them the Medicaid.
Right. So my child has been disabled physically and mentally since birth and is now 17. Any recommendations? Apply now and get on the wait list so we can get on a waiver. Have had services and been in the system before. How would we see if we are still in the system?
So how you would see if you're in the system, absolutely email me and I'll let you know if we have you in there or you're already on the waiting list. If the answer is you're not currently on our waiting list and would need to apply, then my advice is going to be that I would encourage you to apply quickly and yes, absolutely get on the list if eligible. Because what will happen is when the student is turning 21, I only go down the list of people known to me on the waiting list. So if you didn't apply and you got to the age of 21, there is no magic list out there other than what I have of students across the state that might be turning 21. So there isn't an automatic, you leave the school and automatically get DD. You have to have applied and been on my waiting list for me to even know about you to make that offer. So you would need to apply quickly.
Okay, as far as combining the divisions, how would that impact the first dollar in? And where will it go?
Yeah, so again, and I want to make sure people understand, we're not combining divisions, so there will always be a Medicaid division and a developmental disabilities division. We are just looking at the Hcbs waivers, which are those 4 waivers, and how we administer them. So they would still operate separately. There would still be 4 separate waivers, each having their own eligibility criteria, each being funded independently, but perhaps the administrative oversight is centralized. So but there's not a combining of Medicaid division and DD division per se. We may supervise employees, like from the aged and disabled team. I might work as the director of developmental disabilities. I might have folks that are administering the aged and disabled waiver under my supervision, but they're still Medicaid and they're still working the aged and disabled waiver, if that makes sense. Again, this is really new, that we actually just started making some structural changes to begin learning about each other's waivers through that supervision arrangement.
Okay, is there any talk or plan about offering an autism waiver or covering autism more comprehensively under one of the waivers?
There has been discussion in the past. Honestly, I can tell you currently, no, we are not discussing it right now. A lot of that, I think, is just the world we're in today. We're really not working on anything new. We're trying to maintain as is during the crisis, but it has been a conversation in the past that I anticipate when things slow back down will resurface. And there are certainly the advocacy groups have some other categories of folks that they're also interested in expanding services to. So I think the division would certainly provide education and data and information about the various populations. The issue that will come into play will always be, we could always make a waiver for any population we want to support. It's, does the state have the funding that they can serve those folks? And that sometimes is the piece that has to be put in place. You know, we can write a waiver for a specific population, and everybody could identify it as a need, but we also have to have the appropriation to support that waiver.
Okay, keep going with questions.
Sure.
How are you feeling? Okay. Courtney Miller had previously stated that if a guardian was a Medicaid approved provider, they could possibly bill for day services under Appendix K if they were able to do so due to COVID-19 circumstances. Is that still being looked at?
It currently is not in the existing Appendix K. And again, I'm speaking just for the Appendix Ks for the DD waiver. The aged and disabled and the TBI also have their own Appendix Ks, and had different requirements of paying guardians. Both of the DD waivers have never allowed payment to a guardian for reasons of infrastructure and oversight that has to be put in place. We just don't have that in place today. And so the short answer is no, the current Appendix K does not allow us the flexibility to pay guardians. We don't have that as a setup currently in the DD waivers and aren't currently looking at that.
If DHHS establishes an Hcbs division, is there any conversation about having a fiscal intermediary who could help support independent providers and thus improve self-directed services?
Very good question. Somebody that knows the system. So absolutely, that's one of the discussion points that has to happen when we start to bring staff together and talk about how we're administering the 4 waivers and what's the requirements of providers in each of the waiver and how each of them support independent providers or self-direction. And many states have instituted those programs that you mentioned. So the short answer is yes, we will have to look at whether that's something we need to do in Nebraska.
And thank you, Tony, for being so transparent and not using scapegoat responses during the session. It is very much appreciated. Okay, who is the current DD program specialist, RN, under the Department of HHS? Is there still an advocate to assist with complex medical issues?
So I think you're talking, I think that's a question to the aged and disabled waiver that looks at medical necessity or the medical diagnoses for those kids for aged and disabled. And there are 2 program specialist RNs in that unit, and I don't believe they have changed, but you're really going to put me on the spot because I can't recall the names off the top of my head, but there are 2 in that unit that still have that function to review the medical necessity for the A and D kiddos. On the DD side, we also have a program specialist RN, but her role is not involved necessarily in the eligibility. Hers is more on the ongoing services for folks in the waiver. Most of our eligibility on DD is done with our disability specialists, which are DD staff, and a psychologist and a medical director who look at diagnosis. We generally don't have the nurse reviewing our eligibility. So I think that question is more to A and D waiver.
Okay. I believe Arizona is doing this, paying the guardian during COVID. A comment there. Another comment, seems like Nebraska has plenty of money. When this pandemic broke, Governor Ricketts said the state had $58 million in reserve. Why couldn't any of those funds be appropriated to waivers? I don't know if that's a question for you or there it is. Do you want to address it? I don't know.
Going to pass.
Okay. Does the department have a plan on addressing the shortage of approved providers to do FBAs? Services coordinators are requesting new FBAs for everyone and stating that's the department's directives. even with those who have FBAs that have been functional for years. It's a huge expense and a strain on resources.
Yeah, so let me first explain to all of those folks listening saying, what the heck is an FBA? That term means a functional behavioral assessment. And really what it is it's a clinical assessment done by a qualified clinician that takes folks that have some maladaptive behaviors, or what you'll often hear people refer to as this child or this adult has behavior problems. So it's an evaluation that looks at the client and really tries to get to the root cause or the analysis of what's occurring here, right? So we all know, for the most part, that any behavior, if you will, that a client exhibits, to me, it's a form of communication, right? So I'm angry, I'm sad, I'm upset, I'm irritated, whatever it is, but people that do maladaptive things, there's a reason behind it. And the focus of a functional behavioral assessment is to have a clinician really evaluate that to determine what is going on. Why is this participant acting out in such a way? As opposed to the previous way that we used to do behavior intervention, is a residential manager would just assess that person and say, well, they're pulling their neighbor's hair because they're mad. Well, only to find out that really they were pulling their hair because they actually liked the long hair and this person had short hair. But until somebody really gets in and evaluates that and doesn't make assumptions. And so a few years ago, we switched the process to say behavior management programs that we work with our participants need to be clinically driven by a good functional behavioral assessment so that we all know why the behavior is occurring and try to help the participant figure out alternative, better ways to meet that need. So the requirement started a couple years ago that folks had to have that done. Yes, there is a shortage of clinicians to do them. Most of the agency providers have actually hired their own clinicians on staff. And so if they're fortunate to be getting services from one of those agencies, their own clinicians are already doing them. But if they don't have clinicians on staff, we are struggling to get folks. One of the things that we did in the recent waiver amendment is we added an additional credentialed license, if you will, that can perform FBAs for us. It previously used to be an APRN, a psychologist, or an LIMHP, licensed independent mental health practitioner, registered nurse, or psychiatric registered nurse, or psychologist. This current waiver amendment, we added a board certified behavior analyst, a BCBA, under the supervision of one of those three professions. So if you're a BCBA under the supervision of an LIMHP, licensed independent mental health practitioner, you now can provide FBAs for us. So we were hoping that by adding in those BCBAs, again, there isn't tons of them in the state, but there are a few that would help alleviate some of that. But I understand it is still a dilemma. The other thing we're doing to help with that problem is the state also operates our own clinical teams. And I have staff on site in Omaha and Lincoln that are BCBAs. And I also have 2 psychologists that if we truly get in a bind and somebody is in immediate need of an FBA and we can't get a community clinician to do one, I do have the capacity to have my state employees come do one for the provider.
Okay, is there any desire by DHHS to offer more training to direct workforce staff, recognizing that there is a nationwide shortage and concerns about turnover and staff retention? Perhaps building a career ladder?
Yeah, so, it is something that we're discussing. And I would say we're discussing it at the national level too. Many states already have that. where the state is much more involved in the provider's day-to-day operations, if you will. Here in Nebraska, we historically have just set up the rules and registered providers and said, okay, go forth and make this happen. And we've kind of stayed out of it, other than overseeing the quality of their services and then paying for services. But there is a push for that relationship to be more of a mutual relationship, where we share the responsibility of the state does this and the provider does this. And so we are having conversations with it, but to be very honest, though, that would, to implement such a program, it's going to take us a few years before we would get to that point where the state has the capacity or the resources, even in staff, to do training of direct care. But we certainly are discussing it with providers, both locally and at the national level.
All right, we have come to the end of the questions that I have.
All right. So just a couple more quick things, and then I'll answer any final questions that you all have. But looking at the slides, we have a couple things left where I just want you to understand terminology of what it means. You will hear sometimes folks refer to reserved capacity or reserved populations. And what that means is that within our waivers, the comprehensive and the day waiver, we've identified with the federal government that there are certain groups of folks that we want to always make sure, if we have funding, we keep a slot on the waiver for them if a dollar comes available for them. So some of these mirror what you saw in the other slides of the emergencies, right? So that's the P1s. So we have a number of slots in our waiver that says, if somebody comes to me as a priority 1 and I have the funding, there never will be an issue that I don't have a slot, because I reserved slots for them on the waiver. It's a technical term that's required with the feds, so that we don't have to turn anybody away if we have the funding. Now, what some people misunderstand is they believe when they look at this, they say, well, you have a slot for me under this category. And that's true, I have a slot for you, but this slot doesn't mean I have funding for you. That's a separate process that you have to get. So that's why I like to explain it, that if you have the money available to you under one of those 6 priorities we talked about earlier, then I have a slot for you over here that we've already reserved. So I never have to worry that folks who do get the ticket to get off the waiting list with that funding offer, I will always generally have a slot reserved for you. And if we ever get close to these, to where we might be exceeding capacity, all the state has to do is submit an amendment to CMS and request additional slots. And so far, every time that we've had to do that over the years, those have been approved and never denied. So I don't think that's an issue of changing those. But I just want you to understand, when you hear people say reserve capacity, that's what that means. There's a slot for folks once they get their funding. Then the next slide, we'll talk about the funding amount and the planning. Again, we refer to it as the objective assessment process, and that is actually the ICAP. So most of the time you'll hear it referred to as the ICAP. The ICAP is just the paper assessment that we use that determines the funding amount that a child or an adult is going to get. Service coordination meets with the participants. We discuss services. This is how you kind of start the process once you get funding. We'll do your ICAP, determine your budget. You'll meet with your service coordinator to talk about services. We develop the plan. You pick providers. A team meeting happens and we develop that detailed plan. And then service coordination monitors that plan on an ongoing basis. The next 2 slides I'm going to kind of skip over because some of this is changed a little bit, but again, the reason these slides are in here, it kind of goes to the school conversation we had earlier when 2 federal entities at the federal level are funding states for services, each one of them say, don't use my money because they already fund this. VR is another one of those agencies like Department of Education that gets money from the federal government to find people jobs. So what CMS under Medicaid says for our waivers is you can't put services in your waiver that Voc Rehab is responsible to do, which is to find jobs and pay for supported employment. Now, DD does pick up the long-term supports that people need, but that initial job searching and all of that is really Voc Rehab's responsibility. It's a much more complex issue than I could begin to articulate over this video, but certainly reach out to your coordinator if you have questions about the VR, or you can certainly email me, but there's some information there about VR. And then the last thing is just making sure to, again, a lot of folks, when we talk about waivers, is understanding the difference when we talk about aged and disabled waiver or DD waiver. And that the aged and disabled waiver, and again, that's the one over in Medicaid, those kids and those adults all qualify to live in a nursing home. And have a whole different set of services in that waiver that they're offered. Our waivers are for folks that meet the intermediate care facility. And again, as a reminder, an example of an intermediate care facility is the Beatrice State Development Center. That's an intermediate care facility, if you've ever been to campus. Or there are a couple other campuses, Mosaic at Excel is an ICF, an intermediate care facility. Mosaic also operates an intermediate care facility in Beatrice as well, another campus style setting. Those are our three large ICFs in Nebraska. There are a couple smaller community-based ones, but most people know the three large facilities. And so people on our waivers qualify to live at one of those institutions. A and D, they qualify to live in a nursing home. And that's the main difference, other than the array of services that each waiver offers. Now, what questions did I not answer yet?
Okay, we have, well, just another shout out. This is the second time I've heard this presentation from Tony and learned something new every time. Thank you. Another question, do we have a reporting and tracking system for any incidents of COVID in the group homes?
We do. We actually just released last week, or maybe it's the weeks are all running together for me lately. I think it was last week, we issued guidance to our provider field. We call them GERs in THERAP, General Event Records. THERAP is the electronic case management system that we use for folks that are on our waivers. We gave instructions to our providers last week of things that we're specifically required to report out on, which are things like people that were potentially exposed, folks that have actually been tested. There's a group of things that we require them now to submit on incident reports to us so that we can track information.
Okay, why are we having to go through another ICAP when the disability has not changed?
That's a good question. So the requirement is that the ICAP has to be done every 2 years. So historically, for those folks who perhaps have been around the system for a long time, we initially did ICAPs when people came into services. And when we began to relook at needing to do ICAPs again, we discovered that some folks have not had an ICAP assessment done in 8 years. And part of the tool process is that it's a fluid process to make sure that it's always being done accurately, and it's currently giving funding according to your needs at the present time, right? So if when you had one 8 years ago, you had a whole lot of needs, and so you had a lot of budget, But over time, your needs have gotten better. You've gotten more skills, or perhaps you had a medical condition that's gotten better, and now you're not using most of your budget, that you're able to get by on less. But you're actually holding up all this money over here because it's in your budget. That's impacting us from using some of that to serve people off the waiting list. Because you're holding it up over here, but you're really not using it. So the idea of doing an assessment every 2 years is to make sure that we're always evaluating folks and giving them funding based on current needs, right? So if your needs go up, your budget's going to go up. But if your needs come down, your budget's going to go down. And every 2 years, that can change, right? So just because this year, maybe your budget went down because you're doing okay, doesn't mean that either at the 2-year mark or any time in between, if your needs change and the team requests a new ICAP, we'll do one. And if the needs went back up, then the budget will go back up. It's intended to be a fluid process that is always done to give people what they need currently. Because people change, right? I think in the examples I gave, people would all agree that sometimes people are better and don't have any needs. And sometimes I like to say naughty. They're naughtier and they have more needs. And so you need to fund accordingly, or they have medical conditions today that they didn't have 8 years ago. So one of the arguments that we had from providers was that ICAP was done long ago. The person now has Alzheimer's and I'm having to do a lot more interventions. So in those situations, you want the ICAP to be done so that it reflects the current needs and increased funding. But conversely, it's also fair then that people that don't have needs also get an ICAP to go back to a budget that meets their needs. And so we administer it statewide for everybody at a minimum of every 2 years to be fair and consistent and to get at current need.
Okay, will the COVID impact the timelines on evaluations, Medicaid, DD, ICAP? I'm fearful that because we are not using services during this time that it is going to be seen as those services aren't needed.
Yeah, that's a great question. So one of the things that's, when I said I wouldn't bore you with all the details in the Appendix K, you brought up one that I didn't cover. One of the things that we requested permission to do is to allow a person to go beyond the 90 days that's currently set of using a waiver service. So current practice from the feds is if you don't use a waiver service in 90 days, we're technically supposed to terminate your waiver. And you would have to reapply and go back on the waiting list. Because of the situation we're in right now, we've asked CMS to waive that if somebody goes beyond the 90 days without a service because they're staying at home with family and they're quarantining themselves and they don't want any services, we won't be terminating their waiver if they go past that 90-day mark. So not utilizing services during the pandemic from an Appendix K standpoint will not impact eligibility for waiver services. We have also requested extensions on completing the ISPs. Medicaid eligibility also has some extensions. And so I think between all the programs, Medicaid and the waivers, we have it covered through the extensions or the 1135, which is another waiver of Medicaid rules that folks are going to be able to continue on without interruption. Even with all the glitches that we might have of meeting deadlines, many of those were extended.
Okay, looks like this is the last one. First off, thank you so much for taking the time to help us. Our son is 17. Besides SSI and getting on the wait list, what other things should we have in place before or at the time he turns 18?
Okay, good. So you mentioned the SSI. So Social Security would need to happen at 18 is when you can apply for that. And obviously the Medicaid then at 19. The other thing that I would, as you get later on in those transition years, if you don't have a service coordinator already assigned to your child, I would call the department and request a coordinator. One of the things that we can do while you're on that waiting list is you can invite us to the IEP meetings with the school to make sure that they're doing what they need to. One of the things that they can help do is make sure that you continue to receive services through the school year in which you're 21, so that there's no gap of graduating and then having to wait till 21. The other thing that they can do is make sure that the right assessments are completed by the IEP teams that will be used for eligibility when we make that waiver offer. But outside of getting the primary benefits of Social Security and Medicaid, I would say those two things are putting you on the right track to being ready for that funding offer, in addition to if you'd like a service coordinator.
Okay, that's all the questions that we have.
Perfect. So I will just close by saying I appreciate the opportunity to do this. I actually love getting this invitation to come talk to you all every year. I offered last year. I'll do this as often as you want. I think it's important that I try to get out from a division perspective and explain some of the stuff that we put out there. I think often we'll say, yeah, go to our website and it tells you how to be eligible. But sometimes it's a lot easier if I just sit down and explain it to you and not tell you to go click on a website, or we have honest conversations about what does it take to get through Social Security and Medicaid. And so I'm happy to do that even outside of this. Again, my contact information you have on the slides, and I know they will be sending it out to you all if you registered after we sent that out today. And I'm happy to answer any questions in the interim as well. And certainly those of you that I asked you to follow up with me, send me an email, and I or one of my staff will certainly get you the answers that you were looking for. But again, I appreciate it. I thank you all for, again, taking the time. You can go back to Netflix or whatever else is exciting on TV to watch besides me.
Thank you so much, Tony. We really appreciate you coming and sharing all of this information with us and answering everyone's questions. One last bit of housekeeping. I am going to go ahead and make the poll, the survey